The content provided in this podcast is for informational and educational purposes only and is not intended as medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a medical condition.
Is it my story, your story, his story, her story, Jane's story, Joe's story? Is it just an allegory? The show's about to start and we still don't have a name for it. Bop, 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 bop. It's a long story.
Aging and cystic fibrosis are words you don't always hear in the same sentence, but on this podcast, you'll hear them all the time. With relevant discussions and unexpected explorations wherever this podcast might take us.
So many people with CF are living longer thanks to modulators and medical advances. We thought it was time to get into some real conversations with expert guests and people from all walks of CF about what living longer with CF means, the good and the not so good.
I'm Dr. Ahmet Uluer.
And I'm Lauren Harvey.
I'm a medicine and pediatric trained pulmonologist and director of an adult CF center at a Harvard-affiliated hospital right here in Boston.
And I've had CF all my life and was recently diagnosed with CF-related diabetes. I am committed to creating a supportive space for those with CF and their loved ones.
I will bring the medical expertise and provider perspective.
I bring the real-life CF experience.
And together we bring you It's a Lung Story, a monthly podcast about aging with cystic fibrosis, where we take a little time to tell a lung story.
It's a long story.
It's a lung story.
Ooh, was that a vibrato?
I did try to introduce a vibrato. And welcome, Andrea. Quick programming note. Sadly, my co-host is out today, Lauren Harvey, and maybe it's the flu, but it's also, I hear there's multiple reports that she's simultaneously, one, ice climbing, two, defending her household perimeter from an organized squirrel uprising, and three, quietly launching a new podcast called The Year Before Your Wedding: Survive, Thrive, and Don't Text Your Ex. So she's resting in her own way.
I'm going with number two, but I have no
Think so.
insider information. So,
I'm going to go with number three.
okay, we'll see. She'll report back, I'm sure.
And then there's our producer, a marketing machine, a force of nature. And if you're listening to this episode, it's because she produced it, promoted it, tracked its analytics, and probably scheduled the next three while we're still warming up.
I'm really good if I can get analytics on an episode we haven't recorded yet.
That would be amazing. It was just like sort of Back to the Future situation.
Mm-hmm.
I don't even know if that works.
Yeah, no,
But
we won't. Yeah,
big news. I hear that we have a new intern.
we do. Sarah Richards, who is our guest on the liver episode, reached out, and I don't know why, but she wants to work with us some more and learn the ropes on how we get a podcast going. She's a writer, so that will come in handy, and she wants to learn how to make and promote a podcast.
Well, she is amazing and you're amazing. So I know that that does make sense to me. And in fact, she should probably, be running this thing too, or she will be.
Yeah, I definitely see that.
This episode is being recorded right before the holidays, but it won't drop until January. And what is everyone talking about? Everyone's talking about something that you reached out to me about, and that is Spotify Wrapped. And there was an amazing SNL skit called Uber Wrapped, which I don't know if you saw, but that was hilarious watching.
It was funny.
People hear back what they ordered. But I did my Spotify Wrapped. There was a lot of indignity with it because I listen to waves crashing or rain falling when I sleep, and also when I'm trying to get work done. I'll have some background noise. So my number one music was alternative music, and apparently I listened to 48 days straight of ocean crashing and rain falling. And so, like, how lame does that make me sound? And by the way, my Spotify Wrapped age then became 88. But like, I'm listening
sure
to ocean sounds. I'm like meditating. It's so healthy, but like, it really made me feel like a loser.
Yeah.
Yeah.
Well, I think, yeah.
I can't wait to hear what our guest Spotify
Yeah.
Wrapped is.
I don't listen to Spotify, so I couldn't do it, but I
Yeah.
did do my Chat GPT Wrapped.
Yeah.
That was also revealing.
Okay. I didn't know that you could do that until you told me. So what did yours say?
Well, I use it a lot for work. It called me a science poet because I feel like I've been digging hard into CF and our podcast here, and also talked about how I'm researching and storyboarding taboo subjects for my podcast while my dog quietly judges me from across the room. Because I guess I've also notified it about my dog, Mabel. And she is a little judgy, to be honest. I think that was like a little pickup that AI got. So one other thing that happens since we're doing that super quick is that somebody went to Africa, but since the last podcast, into
Okay.
a little
Who is
place
that?
called, that would be you.
Oh,
Went to is it Nanyuki, which is
Nanyuki.
Nanyuki. Such a good name, to visit the Leo Project, where you are helping them get access to, basic medical care. And I,
Well,
spoke with you a little bit about it, and we've also been seeing it get some love on social media about helping them with education, clinical protocols, and apparently teaching them how to do PFTs or spirometry.
yeah, among other things, but I feel like they're teaching me and us. Chandra Swanson, our fellow, also joined me. But I would say a quick shout out to Jess Danforth, who is the most humble person, but she has started something with an incredible group of Kenyans, a community health center called the Caitlin O'Hara Community Health Center, and soon opening up an inpatient hospital for maternal health and oncology care. But it's is doing something pretty incredible, and supporting her is super easy. And it was a great trip to Kenya. And, we'll talk about it more, but we need to move on to our podcast and our main event. I want to highlight that recent guidelines from the CF Foundation, led by our guest and her colleagues, have shed light on just how prevalent and burdensome pain is in CF. We're talking about approximately 77% of adults or 42% of children with CF experiencing disease-related pain. And a more recent survey by Ward and others showed that up to 70% of adults with CF report chronic or recurrent pain, and much higher than in people without CF at 28%. And the pain that they report, chest wall, abdomen, back, and joints, is, part of the wear and tear that comes with living longer with CF, but also part of the disease process itself. Yet, despite its high prevalence, many people with CF report feeling that their pain is ignored, underrecognized, and undermanaged. And Karen Von Berg and I brought it up in our plenary at NACFC this year. And the amount of feedback we got about people thanking us for talking about pain was unbelievable. And so we're going to explore how to have supportive conversations about pain and what a comprehensive multimodal approach to pain management looks like. And to help us have that conversation, we are joined today by a professor at the University of North Carolina, Chapel Hill, where she is a medicine and pediatric trained pulmonologist like myself, but she has gone further and is also a brilliant palliative care physician. She serves as Associate Vice Chair for Faculty Development for the Department of Pediatrics and Medical Director of the UNC Children's Supportive Care Team, the Palliative Care Consult Service, and previously directed the UNC CF Center for many years. She has co-led development of guidelines for palliative care and pain management for the CF Foundation and was a member of the Advanced Lung Disease Guidelines Committee. So please help me welcome my brilliant colleague and friend, Elisabeth Dellon.
Yay!
Hey, thank you so much.
All right. Of course. But before we get started, what did your Spotify rap say, or ChatGPT Wrapped, or anything wrapped?
I don't use Spotify, but I will say, I'm embarrassed to admit it would have included a lot of the most recent Taylor Swift album, especially the acoustic
yeah.
version.
Yeah.
Yeah.
That's right.
Yeah, we've become Swifties. And then there was a great documentary, I think it was on Netflix, on Lilith Fair. So it was like all the girl power of the
Oh my God.
90s. And I had forgotten that Missy Elliott performed at Lilith Fair, which was totally amazing. She's so entertaining. But so I've listened to a lot of the classic female
Yeah.
musicians from that era.
I
Liz
do love
Phair,
that
one of my
era.
Yeah,
favorites.
Liz Phair,
Yeah,
amazing.
I love it.
So funny.
McLaughlin, like Natalie
Natalie
Merchant, was she in
Merchant,
there?
yeah, Sheryl
Yeah.
Crow.
Mm.
You
Oh
guys
my
were
God.
shooting our podcast
I
age up
know. Yeah.
into the stratosphere at the
Aging with
moment.
CF and aging.
Yeah.
Well, it's going to be less than 88, so we know
Yeah.
that.
I will say that I've challenged myself. I'm doing my PT to the dance that has like taken over the world, to Taylor
Oh,
Swift, the Ophelia dance.
it's a tough one, though.
It's helping me with my balance and my endurance, and
Oh my
I'm
God.
just having a lot of fun with it.
That's
Good for
amazing.
you.
All right. So we just talked about the plenary and the feedback, and beyond the different pains people are experiencing, their anxiety about pain is their worry for not being believed. And we quoted Noor, Cade, and Casey, who said, and I quote, "Pain is awful, but being disbelieved is excruciating." And just as people with sickle cell have learned to manage perception in emergency room settings, many people with CF learn to manage how much pain they reveal because they don't want to be seen as exaggerating or weak or problematic. And we've talked about this previously on this podcast as well, that looks well bias. So what do you think pain and cystic fibrosis is so often underrecognized or undertreated, even though we see it's so highly prevalent and deeply impactful?
Yeah, I mean, it's a huge problem. We know that in many conditions that's the case, and certainly in CF, the available literature probably tells us more than clinical experience as a clinician. I don't hear a lot about pain from my patients, and probably that's because I'm not as good at asking about it as I should be. I think that's one of the challenges that we face in healthcare in general, right? And so I think, as in any condition that is painful, people really learn to live with a lot of discomfort and low expectations about that being addressed or managed. There's a lot of fear and stigma around treatment for pain. And so just even imagining having that conversation with a clinician can be difficult for patients, and clinicians are anxious about treating pain, so probably aren't doing as much as we can be doing just to investigate that as one of the symptoms that people are experiencing. But I think in CF, we have, every time you come to clinic, Andrea, you can certainly um, speak to this. We have this big checklist of things that we try to get through. So many organs and systems are involved in CF. There's so much going on in the life of a person with CF. And I think pain just gets down lower and lower if we want to try to get to the top concerns of any given day, and pain hasn't come up in conversation before, it's not going to occur to the clinician, and the patient may be less doesn't feel necessarily empowered to bring it up.
Where I go, they often ask, "Are you in any pain?" And I'm always like, "Yeah." But, like, I know that you wanna know, am I in pain relative to the visit where I'm at? Like, if I'm here for pulmonary, do you wanna know about my back pain? Or if I'm here for back pain, do you wanna know about my tendinitis? And then most places, I'm like, "Why did you ask? We didn't even talk about it," and I know that goes back well before visits had to be 20 minutes. It just wasn't a hot topic. And I don't think until I got into like my mid 40s, started to wonder, was it like, did I also have all of these pain issues as a side note to CF or because of CF? And, started to search around for answers, and I really honestly couldn't find any, and nobody had any, you know. And that would have been about 10 years ago, just so everyone can know, when I started like having um, like fibromyalgic aches and pains. Um, and I was like, do I just have that plus CF or whatever?
So I like what I'm hearing. There's this also like background noise of pain. And so you're like, is this, this is just my usual life and we haven't talked about it. So what are you asking now? I don't know, Elizabeth, that's what were you about
Yeah,
to
no,
say?
absolutely. You hit on something really important, right? I guess in healthcare, we think about pain as an additional vital sign, right? It was sort of added on at some point in, I don't know, a few decades ago, right? Of asking about pain while getting checked in and having your pulse checked and your temperature checked. And so it's usually a scale, and people give you a number, right, from 0 to 10. And certainly there needs to be follow-up to that. If there's a number given that isn't 0, but even when it is 0, is it just that I don't know what pain you're asking me about, right? And like you said, I have pain from multiple sources, but what does this particular, clinician or team want to know about today? What are we actually going to talk about? And it can really be confusing, or it can feel like not a great use of time because you just feel like you're not likely to have your concerns addressed.
Now, the CF Foundation and your guidelines emphasize routine screening and assessment. I know that on our plenary, we showed what everyone recognizes, that board scale and the pictures of, a face from happy face to, someone who's in excruciating pain. But I know that PROMIS and, the patient reported outcomes measurement information system is what is being recommended. But you're also a palliative care doctor. And I was wondering if you combine that with some of the other outcomes that maybe you use in your palliative care work.
Sure. Yeah. So that was the main measure that was recommended after a really exhaustive search of kind of available measures, right? And thinking about what's feasible as a screening tool, with the idea being that you have something really simple that you ask a person and then you do things after you get the response, right? So it's just kind of an entry point. But that really is basically the sort of 11-point scale of, 0 to 10. How would you rate your pain? Now, it's only asking pain generally, right? But we should dig in and say, the pain that is occurring in your chest or your headache or your abdominal pain, how do you rate the intensity of your pain? And then we also have a scale looking at pain interference, because we know that the experience of pain is different for everybody and for every location and type of pain. And so I might have 4 out of 10 headache every single day. It doesn't necessarily interfere with what I'm doing because I'm very used to living with that, and I've figured out how to adapt to living with the pain. I've made accommodations in my day-to-day to be able to function. But maybe I'm having 4 out of 10 abdominal pain, and that's unusual, and I'm worried about it. And it's making me change my routine. Maybe I'm taking the day off from work, or I'm not going to class because I'm afraid of what that might signify, or because I'm too uncomfortable to do the normal things that I do. So the intensity report is also very important. And the focus is really on how it interferes with your daily activities, your enjoyment of things. And so there can be a real range of intensity and interference for any pain type, and how much pain affects a person's activities and quality of life can really vary.
I remember when I first was dating and engaged to my husband, I'd get like a sharp pain in my ribs, which I had, grown very used to, like gas pain, like referring all over. And I'd be like, oh my God, oh, like grabbing my side. And it's like, oh my God, we have to use an emergency room. I'm like, no, 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 it's just gas. It passed, like, it's like, and he was like,
Hmm.
what the hell is going on
A sign
here?
that he's a keeper, though, if
Um,
you told him you had gas pain and he stuck around.
yeah, yeah, he's, yeah,
I was going to
yeah,
say,
he,
but
did.
underscores just like that is your usual, like doubling down. I mean, like, or like just that in that kind of
Ooh.
pain, you're just like, that's just normal
I mean, at the,
for
that
you.
like era is a little bit over,
Yeah.
but the other stuff, but I know that certainly in our community, there are people whose, normal is an 8. And I was told by a nurse when I was filling out a Borg scale once that she said, I just noticed that all people with CF come in here and they underrate their pain, probably for the exact reasons that she didn't articulate it quite as well. But like you're so used to living with it that you almost like you put your baseline at 0. And so
Yeah.
I'm always like, I can't give it an 8, like, because I know what a 10 was that one time I had a bowel obstruction. And I was sort of like, yeah, well, I'm not gonna give this a 7 because what if it gets worse? So
Elizabeth,
anyway,
do you feel like we need like the pain scale, the promise scale? I mean, are there other ones that you're using? Is that really, the best one out there? I'm not saying that it's not, but just like, is that like, I guess my other question was that, there's this, So I was doing research for our conversation, integrated palliative care outcome scale, which has like a pain subscale in, certain like questions within it. Is that, are those similar questions? Does that get to pain a little bit differently?
That gets also to sort of interference with activities and quality of life. And I think those are, it's really that combination of things. And again, the idea behind all of this was that it's an entry point into a more in-depth assessment. So it's just acknowledging pain is common. We expect people may have pain. Let's see if people indicate pain, how it's impacting them, and then try to figure out what's causing it and what approaches we might be able to take to mitigating or at least reducing the discomfort and the level of distress or interference with activities.
So, and that gets me to my next sort of question is that, pain is obviously super complicated. And now we know that there's a lot of people suffering from depression, anxiety, and that impacts our perception of pain. So I know that there's this pain CF program, pain acknowledgement, coping, and empowerment. What are the components and how can CF centers integrate the understanding of depression and anxiety and its role in CF? Like with our mental health consultants and coordinators.
Yeah, I think you're hitting on a really, really important piece of this, right? Pain co-occurs with many things, many other symptoms, and there are many symptoms or conditions that people have that will either exacerbate pain or intensify the experience, right? So depression and anxiety are certainly among them. We know that they're highly correlated. We know that in order to effectively treat pain, if someone is depressed, we have to address the depression as well. If someone is endorsing pain and they're anxious, especially if there's anxiety related to what the cause of the pain might be, we have to address both or we won't make headway with either effectively. So I think the idea is to really take an approach that addresses the factors, not just the sort of physiologic or what are the issues related to CF or other conditions or whatever it might be, an injury, other pain sources that are causing and contributing to pain, but what else is there and who else can be involved in helping address the causes and contributors?
Absolutely. I mean, so that's exactly it. There's so many things so when it's not just about the pain, it's about what's going on. And Andrea, I know that like sleep, when that's messed up, I know that kind of messes up your day.
Yeah, and menopause, sleep, that little vicious little cycle of losing sleep and depression, it does make the pain worse. I'm sure it's a super deep dive into brain chemistry, but I can just tell when I'm having a bad day because my right knee hurts. No, I'm just kidding, but it's sort of like that. It's a head game because then you're like, well, am I making it up? How much of this is like it's so much worse than it was last week and I didn't really do anything different? And then there's like, well, do I call anybody about this or do I just suffer through it? And I think lack of sleep just like destroys your ability to have like a rational discussion in your head during the day. And I have the added bonus of like not being able to take a nap. So what I get is what I
Yeah.
get pretty much. I lay down in the middle of the day. It's
So
more
Elisabeth,
anxiety.
yeah, Elizabeth, when you are assessing pain, how often is it something you feel that you can intervene with, like sleep, or providing psychopharm treatments for depression, anxiety, or behavioral interventions? When you're looking at that sort of approach, where are you finding the biggest sort of contributors to pain?
Yeah, I would say again, there's sort of this like bidirectional relationship with pain and all of those things. So if someone is endorsing pain, especially chronic pain, right, we know that certainly you adapt, like you mentioned, Andrea, to living with a certain level of pain, but pain changes you in many ways as well. It affects a lot of things and it will certainly contribute to worsening of mood or anxiety, sleep disturbance, daily function, lots of the interventions that we can think about for pain really do need to address those issues as well. So that's where I would say we as CF clinicians want to utilize our amazing multidisciplinary team and bring in our mental health experts to help assess the components that might fall into that realm. If we have access to respiratory therapists or a physical therapist to think about how we might be able to adapt activities to a place where they can occur, but maybe be done more comfortably. If sleep disturbance is contributing to pain because you can't rest at night, and then, like you said, Andrea, that you're just everything you can't, it's more of a head game of, is this something that, I need to be worried about, or am I feeling worse because I'm sleep deprived? We want to be addressing sleep disturbance and what's causing that. We really want to be thinking about who can we bring in to help assess and come up with some interventions, maybe that aren't necessarily pharmacologic, right? Aren't necessarily medication, but certainly in conjunction with medication if that's appropriate, or with treating underlying causes with the other tools that we might have. Say for abdominal pain, right? Lots of causes of abdominal pain in people living with CF, and often with adjustment of medications for reflux or our pancreatic enzymes or constipation, laxatives for constipation or hydration, we can affect some improvement on pain. And so we're never not thinking about trying to improve what's going on underneath. If we're having a pulmonary exacerbation and that's contributing to chest pain, of course, we're going to treat that. But we want to know how to what else to bring into the mix to help alleviate pain during those times.
You brought up chronic pain. I mean, that's really what we're talking about, because that's what's inflicting so much suffering to our CF community. I know that sometimes we're disappointed by our pain consults that we get in the hospital or in other places, because really they're experts in acute pain management. And so I feel like your background in palliative care, because I feel like palliative care really offers that sort of holistic approach to pain. And I just can't imagine a better person to run into than you with your palliative care background. But how do you feel palliative care providers are doing with chronic pain?
I think that depends a lot on the resources, wherever you are receiving your CF care or what's available in the community, how a palliative care team is staffed, who's a member of the team, where are they practicing, is it inpatient or outpatient, and who do they collaborate with, and what does that look like? So I think it's highly variable. I want to make sure that there isn't sort of a thought that it's like readily available and accessible, and that every palliative care team does a lot of chronic pain management, because many don't. They just don't have the resources. And there are certainly chronic pain programs that are available in many places, but not everywhere. So whether that includes a pain specialist who's maybe trained in anesthesia or another field, or whether it's palliative care clinicians, those programs tend to also include folks like physical therapists or occupational therapists or integrative health specialists, mental health specialists. So really kind of taking it takes a village approach to try to holistically address chronic pain. And really that is, in my opinion, would be ideal if people had access to that. I think access is a major issue. Also, it's a burden for people living with CF who are already dealing with so much every single day to bring in a new clinician or a new team, a new specialist, especially if there isn't, a clear guarantee that they will benefit from it, right? So really encourage people to utilize the resources that they have. And I think it's our job as CF clinicians to help, to really partner with those specialists and help educate them about our experiences as CF clinicians with the types of pain and the pain experiences in the day-to-day lives of people living with CF, to give them some background to help when they're meeting folks who are struggling with chronic pain and have CF.
Yeah, and that's exactly it. I did not mean to insinuate that access is the biggest issue. We're privileged in the Northeast, and even here it's not perfect. I mean, people are going to probably now start moving to CU in North Carolina. But I think it's just like, and as you said, I mean, and Andrea, you can speak to this, but, to tell your story again to another person while you have this CF multidisciplinary care team who knows you. And so people look to that care team to manage their chronic pain. And I always feel that we're in a position where we're not pain experts and we are trying to manage something, and we don't want to get someone into trouble with treatment. I mean, your guideline is one way of doing it, but how do you train a group of people who really are either not trained to take care of pain, but also are reluctant to take care of pain because of they're concerned with the opioid crisis going on and not knowing some of the other subtleties of how to treat
Mhm.
pain?
Yeah, it's a fantastic question. And of course, there's no easy way to do that. Our hope is that, and the guidelines, we focus a lot on just sort of some general recommendations for pain assessment and management, that a lot of it honestly just comes down to good communication, screening and then following up and doing an assessment and thinking about what's going on with the individual person, what they've tried, what they haven't tried, what we are comfortable with as clinicians with sort of our basic pain management training, which should be part of our skill set. And in the world of palliative care, we think about basic management of pain as being like a global, like general skill that any clinician, who goes to medical school or has a nurse practitioner, advanced, practice providers have from their training and practice. So we want to employ those skills. We, in the guidelines, put together as many practical resources and references as we could possibly find, knowing that everybody likes to learn in different ways. I do want to point folks to some great tools that have been put together by some good friends of ours at Mass General and Emory and Mount Sinai from the Improving Life with CF Primary Palliative Care study. Those are available online. There are some patient-facing materials and clinician-facing materials that include training materials that address pain. So that's one great resource. There are lots of others out there, and we, through the North American Cystic Fibrosis Conference and then some kind of implementation tools, and we're kind of in that phase with the guidelines right now, we'll have some additional resources and training opportunities for CF care teams. And of course, it's not I keep saying clinicians, right? But, it's every member of the CF care team has something that they can contribute to helping people with pain. So we want to really highlight, too, the strength of the multidisciplinary team.
Well, we're going to post those on our
Great.
website, those resources. So I really appreciate that. And you said that it is really the team approach. And, one of the things we highlighted in like growing older and being healthy and have a good quality of life is movement and exercise. And people with pain feel like that's the last thing I could do right now is I'm in so much pain. How am I going to do that? But the physical therapist does have a significant role. And I don't know if you can expand on that, how movement really can help with pain.
Yeah, so there's just a tremendous amount of evidence that exercise is good for, essentially everything. That, but certainly pain being, and of course one of the hardest things to make ourselves do as humans. But any amount of exercise and just physical movement of the body just helps with things like muscle strength and agility and endurance and range of motion, all of those things that really contribute to when they are restricted or are affected by a painful condition. The more we shut down and slow down, the harder it is to do the physical tasks that we need to do and the more uncomfortable those become. So exercise comes in many forms, and there's some fantastic resources. And of course, I'm blanking on the wonderful CF-specific exercise sort of online resources. I'm sure you guys are very aware of, like an exercise program that includes things like, just basic stretching and yoga and things that people can do at no cost with no equipment and to whatever extent that they can do them to keep their bodies moving. And then we know that there are people who really need a lot of support and actual physical, medical kind of supervision for safety purposes, right? If you have more severe lung disease or if you are living with other physical disabilities, having access to a physical therapist or a pulmonary rehab program to support exercise can be really critical.
Just from the patient side, I think, there are so many non-traditional things that over the years, I've picked up. I don't think it's a good idea for me to take pain meds, obviously with GI issues from that. And I've never done that unless I had like a major surgery. But I do everything from meditation to talk therapy, PT, just to keep my GI system from not being irritated and upset. It involves cooking and making my own food. I mean, it's like it adds up, like all those things. And what do you say to people who are like, oh my gosh, I'm not able to do all of those, like keep my appointments, take my meds, do my treatments, and then do these extra things that are, they do have benefits, but you kind of have to be in it for the long haul. I find when I'm like really bummed out about pain, I just like a really good distraction, like work or a movie or something like that. And I will blow off some of my other stuff to just do that. And that seems to, for 2 or 3 hours or whatever time, it does seem to work. I guess I'm just sort of saying, like, at some point when you hit the ceiling of what you can do, what do you tell people who are just like at their wits' end?
Yeah. I appreciate you bringing that up. And I'm sorry that that is an experience that you have. And I think that is many people with CF have that, would share that as a part of their lives. I think that what can we do and how do we prioritize, right? And what can we shed or give up? What's possible to sort of push aside to take the best care of ourselves is always a conversation we want to be having. One of the things that I think a lot about when I'm assessing pain is thinking about wherever the pain location is or the type of pain someone's having, the intensity and then the interference pieces being so important, right? What is interfering with and how could we be working around that? But also, what are the ideal conditions, right? So if on an average day, this is what my level of pain is. On a good day, this is what it is. On a bad day, this is what it is. I think it's important to kind of know that range. How do we get to more good days? And that does often involve that sort of prioritizing and picking and choosing, right? Recognizing that you cannot do it all and adding and adding and adding. Something's going to fall going to fall off or fall
Yeah.
apart, right? So what are the things that we can set aside to prioritize getting that pain down to at least what you might feel you can live with on a typical day, as opposed to a bad day. That's not a very specific response, right? But having honest conversations and helping people again think about what they maybe don't need to be prioritizing or spending time on when it comes to their health as a clinician, right? I can ask those questions about their day-to-day lives, like what can you get off your plate? But a lot of people don't have options with that either. But maybe we can think about what part of your health is like stable right now, and could we maybe focus a little bit less on and spend a little bit more time on some of those things that might help you feel less uncomfortable.
And you didn't get any of these questions ahead of time. This isn't easy, and it's very specific to the person that you're seeing in
Yeah.
front of you. I mean, you can't give general advice here on what to do. And I want to bring up like two maybe cases. One of them that we've already talked about, but one of it is like, let's say that there is somebody who, when they're coughing, they're having so much chest pain, and maybe they have a fracture, or maybe their just chest is sore, and they need to do airway clearance. Like, how do you approach someone that's dealing with a therapy that they need to do, or that's going to help them reduce that cough and exacerbation, but they're just so uncomfortable? Like, how do you approach someone with like chest pain from that needs to use the vest or do airway clearance?
Absolutely. So in the guidelines, I just want to point to there are a few things that we could make specific recommendations for CF, right? There's just not much out there in terms of evidence for pain management that is specific to CF. Acute and subacute chest pain do actually fall into those categories. And actually, for acute chest pain, if someone is in the hospital and is having maybe very severe pain from an exacerbation or has had, a pneumothorax or another complication, there's really good evidence for actually procedures to help manage that pain that, say, an anesthesiologist would perform to block a nerve that's injured and causing the pain. And so that's something we should always keep in mind if people are hospitalized. That's probably not a really realistic, sort of day-to-day thing at all. But I do want to point out that we should never be forgetting that those procedures exist.
A home anesthesiologist.
Yeah, that'd be so great. I know.
Yeah.
But I think pairing in general, when someone is going through a much more severe level of pain and interference with pain because of something like a pulmonary exacerbation, we want to think about combining medication management, pharmacologic management that's different from the day-to-day, even if you are taking something that is related to, that's for pain that is related to chronic chest pain, which many people would not be, with kind of the other options for non-pharmacologic things, like would some physical therapy or massage or heat or ice or topical treatments be helpful in alleviating pain, topical medications, and also things like modifying what our airway clearance looks like during those times, right? Maybe I can't tolerate my vest, or I can't tolerate my vest without perhaps putting a barrier between the vest and the area of my chest that hurts. If it's not, getting as much of a pulsation, maybe it doesn't hurt as much. So sort of modifying those things, but maybe bringing in other devices that can help provide airway clearance if folks can tolerate that. And I think the pharmacologic piece has got to be really tailored to the person. So if we're having acute chest pain and we know that it's worsened by airway clearance that we need in order to get through the exacerbation, then we think about pre-medicating with a short-acting pain medicine before we start our airway clearance. So if something like acetaminophen or Tylenol, helps enough, we may choose that. If we can take a non-steroidal anti-inflammatory drug like ibuprofen, like we're not on a tobramycin IV or something where we wouldn't want to be using those two because we don't want to injure the kidneys, we might pre-medicate with that. But sometimes we do need to think about an opioid pain medicine when someone is in so much pain that they can't tolerate their therapies. We just don't want them to be in that much pain anyway. But for the short term, even though opioids can pose a lot of challenges in lots of different ways for people, sometimes that is the best way to help get someone through a severe pain episode so that they can heal and get off of the opioids and return to a better level of function.
Yeah, and I'm glad that you brought that up, because prescribing opioids or someone asking for opioids, there's just so much stigma, and just the communication is just so difficult. And, I know that I've had this conversation with a lot of people, but that feeling of being labeled drug seeking, and you're like, wait a minute, I'm not drug seeking. Like, I know that's something that happens all the time. And then you're trying to redirect the conversation so that you don't feel that way, especially when you're talking to people who don't know you, like you're inevitably in an ER. But how do you navigate those conversations? How do you help people have those conversations with other providers they don't know? Because your suffering is a big worry. And I know that patients want their providers to, I don't know if the word is like them, but to want to know that they are, like, they want to work together. They want them to trust you and you to trust them. Like, how do you navigate that conversation? Which is obviously an impossible question, but I'm just going to throw it out there for you to see.
I got a one-line answer for you.
Like how you might, yeah. Just, and if you could keep it in 30 seconds.
No problem. No, it's extraordinarily challenging. I mean, there is an opioid epidemic, right? We know this. People's lives are affected by complications of opioid medications. I mean, I haven't run into a single person I've seen as a palliative care physician who has not been anxious about opioids for some reason, someone in my family or my own personal history. And also, there are just tremendous stigma attached. I do want to point out that, just for listeners to know, there's no evidence anywhere that people with CF, despite the level of pain that people live with, have any higher rate of substance use disorder than the general population. And in fact, it may actually be lower. I think that in terms of just access to opioids in a medical setting, right, because we are so restrictive in prescribing because of concerns about side effects. We know that there are real GI side effects. We know that we should be able to manage them. They could be challenging. There's a lot of worry about respiratory depression for people who have more severe lung disease. We know that if we prescribe safely and monitor closely, that we are not going to cause respiratory depression. But those things can happen when safety isn't the priority, or when there are errors, or when people are getting these medications, outside of a controlled medical setting. So, yeah, I think I always try to remember, or to remind my colleagues and myself, right? Pain is real. People experience pain. Pain is multifaceted, right? What is pain that's coming from part of your body or that is related to dysfunction of the nerves, something going on in your central nervous system, and what component of pain is the experience, right? It's the sort of concept of total pain. Many things contribute to what it feels like to hurt. And so we do need to listen to what people's experiences are and really taking a thorough history and really carefully approaching prescribing of opioids is the only way to do it. We should all be doing this and always planning on deprescribing, right? So when someone's pain is controlled or the pain source is treated or reduced because of other measures, that we are working on a way to reduce and then eliminate the opioids if possible. I think
Yeah.
I'm talking a little too long, but I just want to say I always want to
No.
remind people too that there are lots of things that are good adjuncts, even medications, certainly non-pharmacologic things, but even medications to pain management that we should just never forget about. We tend to think like acetaminophen, nonsteroidal anti-inflammatories, opioids. We don't think about myriad other things, and we've included a lot of those other therapies in the guidelines. We should be thinking about when to introduce those medications as well to try to spare opioid prescribing.
Yeah. And like neuropathic pain, there's medications for
Mhm.
that.
I'm going to be honest and say not in CF, but some experience in the opioid agonist antagonist medications, buprenorphine. I can't ever say that correctly. For
Yeah.
example, that maybe there's maybe a role there because we're sparing some of the side effects and some of the more neurological and psychiatric effects.
Buprenorphine. I know now rules have been relaxed that prescribers, like even myself, can prescribe it. Used to be pretty
Mhm.
restricted, but it does seem like a medication that we should be using for especially those who may be having more difficulty with coming off these opioids. And what's your experience with it? And do you think that more people should be prescribing it? Is it just right the way it is? Like, what were your thoughts
Yeah,
on it?
again, I'm not going to be able to comment on this specifically
Yeah.
for people living with CF because there's just the experience is very, very limited and maybe shouldn't be, but it is. I will say that kind of in the palliative care world, there's been a lot of move toward increased utilization of, that class of medications. Just thinking about some of the benefits of sparing some of the side effects and some of the tolerance issues that we come up with in other opioids. So we'd like to see increased utilization just for safety issues and for tolerability issues. I think I would really encourage people to utilize pain specialists, palliative care specialists in prescribing if it isn't going to be something that you're going to be doing on a regular basis, because it is a little bit different. It's kind of outside of the scope for most CF clinicians, and often is something that really is best managed by somebody who manages it a lot in people with other health conditions.
Now, I just ran into this person in the hospital and I told them that I'm gonna discuss this, but back in 2011, we talked about this person who was approaching the need for a lung
Mhm.
transplant, but was having a lot of chest pain and difficulty with airway clearance. And opioids were not an option because if they were on opioids, they were not be able to be eligible for a lung transplant. And this person now 13, 14 years later still has trauma from that and still actually doesn't forgive us and the transplant team for not providing enough pain medication. And, thankfully she got transplanted because she could have been in all that pain and
And
then
didn't survive.
not received
Mhm.
the transplant. But I told this person that we would have a quick
Yeah.
discussion on this because that was, I mean, I'm traumatized by that. And every time we talk about it, I wish that I had advocated more.
Yeah, this is a tough one for so many reasons, and I'll acknowledge it's a tough one for me emotionally, thinking about people who I've watched go through torture for the same reason, right? I don't want to lose eligibility, and that's just the way that a lot of transplant programs practiced historically. I think there's been a bit of a shift, at least in some programs, where there's a recognition of, the very important point, right? That we're hoping that this person will live to receive a lung transplant, but if they don't, this is the end of their lives and they're in terrible pain, right? We would never want that for anybody. Also, if our hope is that people go into transplant as robust, sort of physically as they can be, having good pain control is really important to be able to optimally, participate in physical therapy and, exercise, be active, optimize nutrition, all the things that we know are really important to outcomes in transplant. People tend to do better if they come in healthier. Their recoveries are faster, they get home faster. And so I'd like to think that we could be thoughtful about cautious prescribing of opioids for the purpose of improving quality of life for people who are really struggling and potentially nearing end of life and who have a lot of hard work to do in order to be eligible for transplant from just a global perspective, right? We want to help them get to that goal.
I really appreciate that answer. And it's really not easy. And we want to make sure that people have great outcomes with transplant. And I think you bring up a good point. In order to have somebody who's able to move and exercise and have that core strength to do well with the transplant, we need to address their pain. Before we go to the next phase, what are the things do you feel like are unanswered from our conversation today? What do you think people need to know about, or what hope do you have for the future of pain management in CF, and what keeps you up at night?
Again, I'm just going to say this all comes back to communication, talking to people, opening the door to people with CF, reporting their pain, letting us know what's going on so that we can try to address it as opposed to just dismissing it or, leaving it to someone else, right? Kate and Casey and Noor wrote this beautiful piece, had this lovely conversation with Jane Lowers, an investigator at Emory, who is an incredible qualitative researcher. And they just did this. I can't believe what came out of that. It's hard to read, and it's also incredibly important. I recommend it to everyone. But to say we love our CF teams, right? We really trust you guys. We need you to listen to us. And I think that's the part that we just have, that if we just simply do that, and then we're kind of got to hold ourselves to figuring out what that next step is, right? Learning how to partner with folks who have expertise in mental health, in physical therapies, in integrative therapies, if that's something people are interested in and have access to, in pain, in palliative care, so that we can co-manage and help people, live more comfortably.
Sounds like you also need to have a bigger seat at the table with the transplant folks.
I mean, the word I use is trust. Trust is hard to achieve and very easy to lose. And a shout out to my colleagues who were doing research in trust. But I feel like that you brought up communication. I think that all sort of goes hand in hand. And the only way to be able to do this work together is to trust each other. Because if you're telling somebody, this is what we can do, or, I'm doing my best, to understand that that's, what's happening as well. Andrea, any last questions on pain?
I did have a theoretical question, which is like, how shortness of breath is extremely uncomfortable, but it's not really widely considered pain. Where would you put it on the spectrum, and how does the brain process that discomfort versus like lower back pain or, something that you would have an easier answer for?
It's shortness of breath pain. Yeah. So interesting.
Like rating your shortness of breath, right? Or how much it impacts you. I mean, it is discomfort, right? It's not necessarily quote unquote pain in the traditional sense that we think about, but there's certainly a spectrum of it, and it's something that changes. So again, how bad is it and how does it affect you are really the key questions there, and thinking about what the interventions are that can help get the shortness of breath to a point where you feel like you can live with it and function. Of course, taking it away would be the best thing we could possibly do, but we know that isn't realistic in a lung disease, right?
And Elisabeth, you mentioned this in a previous conversation, but I mean, discomfort is on that scale of pain now. And I think that does allow for this deeper conversation.
Yeah. That's the idea.
Yeah. Yeah, no, things like shortness of breath, tinnitus, things like that just add to the pile.
Well, it's always tough to segue from such deep
But we always do it.
conversation, and that's heavy, and we do
I mean, we
always do
don't
it.
have to. I don't need to embarrass myself even more.
No, you're going to embarrass yourself. We have a rapid fire game, and what's going to happen is that we're going to ask you a question, and you're just going to give an answer off the top of your head. What first comes to your mind? Andre and I are going to alternate asking you that question, and then Andre is going to assign you a score. I think the highest score now is in the millions.
Yes,
So it's a really it's a complicated equation how we
Sounds like
calculate.
it.
But Andrea, why don't you go first?
Okay. Instagram or LinkedIn?
Instagram.
Sweet or salty?
Sweet.
True or false? I can do a great Billie Eilish imitation.
I'm going to say false.
So you don't think you can do it, Andrea? I feel like you could.
I don't.
No. Okay. All right. I'm not
I
gonna
could do
put
Liz
you on.
Fair, but
Not gonna put you on the spot.
Older. Yeah, 88.
All right. Harry Potter or Lord of the Rings?
Neither.
I love it. Neither.
Honestly, I'm a
We've-
terrible person. I
you've
hate them
lost.
both.
You hate them both.
Yeah.
I love that you hate them both
We
so
learn
much.
something every time.
Yeah. And I mean, there's people who like really feel so strongly about those two, books and movies that people might have just tuned you
I'm
out.
sure they have. My own child included, who told me the entire Harry Potter series on like a 3-hour walk along the beach, like stream of consciousness, like book 1 to book 9. So now it's like I read
And you'll
it.
never forget. You'll never forget
But
it.
I mean, what a
Okay.
lovely moment. Yeah.
Here we go. Next question is heat or ice?
Heat.
Would you prefer the power to fly or to read minds?
Oh, definitely to read minds.
That's so interesting, right? Because we can kind of sort of fly. I totally agree with you.
All right. True or false? Ahmet listens to his podcast at 1.5 speed.
I would have thought double, 2 times speed. So yes, true.
Oh, shoot. It's false. And I won't go above like 1.25 because I really feel like, especially if I'm listening to someone like Conan O'Brien, where comedians have sort of a tempo or, when they're saying something to be funny, like
you
I
lose
feel like
that.
they want to be listened to at their speed. So I like, and my wife and I have this argument all the time because she's listening to it like 5 times speed. I'm like, what? But like,
It's like the chipmunk.
but
Everybody's got
anyway,
their thing.
but that's my reason. Taylor Swift or anybody else?
I mean, lots of people, but I do like Taylor Swift. I'm not gonna lie. Yeah.
Yeah, we heard that. We heard that.
Okay. Silence or background noise? We know
You
what
know how
Ahmet's
I-
answer
we
I
is.
know
know
how
your
I feel.
answer. I actually prefer silence.
It's amazing.
All right.
I just can't. If I'm in silence, I mean, I'm losing my mind. Not losing my mind. I just can't focus. I probably have ADHD, which is obviously what that is indicating. Audiobook or physical book?
Physical book.
All right. And this is our bonus question, which is sort of like a little bit more of a descriptive answer. When Hollywood makes a medical drama about CF or transplant, what's one mistake they always get wrong?
Oh gosh, so many.
So
I
many.
know.
Just think about Grey's Anatomy.
Yeah. Oh, I'm thinking about 5 Feet Apart too, which was just so sweet, but there was so much that was messy. I'm trying to think of
Yeah.
Just the number 5.
Well, yeah,
right
that was
there.
the biggest mistake right there.
Yeah. I'm like, what was that?
But
Why?
they got the drama
Yeah.
right and the emotions right, but yes, the
Very
technical
bad.
stuff we
Yeah.
glanced
We all
over.
wanted to watch it, but we were all screaming at it.
But I did like. I think
did
you're
like it,
saying you
yeah.
liked it as well. It's
was
just
like-
that it was often wrong.
Yeah, there was a lot of
It felt like
infection
an
control stuff that was
acknowledgement.
a mess in that movie.
Yeah.
Not just the 5 feet instead of 6. Lots of weird stuff.
We'd like to invite the director of 5 Feet Apart onto the podcast to come explain himself.
I mean, I think the
Or
5
herself.
feet was, that they
Violated
wanted
it.
to, push back against that rule. But And I do recommend a great read on the New York Times Modern Love, a piece that someone I know wrote with CF in 2006 about like sort of washing away infection control guidelines. I just love that.
Yeah,
I
I've
love
read
that
that.
piece.
I
Yeah.
read that. Yeah,
But and
really
I love the Modern Love section. What am I going to
amazing.
say?
Kind of ahead of its time.
Yeah. So, Elisabeth, thank you so much. Thanks for tolerating that last part. We really appreciate all of this. And Andrea?
Well, I'd like to ask you if you wouldn't mind singing the very last verse of our song.
I can't do this.
And 1, 2, go.
It's a long story.
Woohoo!
That was
awesome.
actually, that was so good.
You
That
didn't
was
ask
giving
really
me
you
to
good.
so
put
many
it through a
extra
Taylor
points.
Swift tune.
Well,
Well,
our
thank
goal
you
is to
again.
get Taylor to come on the show, right?
It is our goal. Okay, Andrea.
That's a wrap for this show. So until next time, get a little older.
Live a little bolder.
We are working hard to provide meaningful information to a deserving CF community, information you won't find anywhere else. If you'd like to help us grow, we'd greatly appreciate it if you would follow us on Apple Podcasts, Spotify, or wherever you get your podcasts, so you never miss an episode. Want to go all in? Leave us a rating and a review. It helps people find us and makes a big difference. If you found this episode helpful, please share it with a friend, family member, caregiver, or provider who might also want to hear it. This helps you, it helps them, and it helps us spread the word to those who need to hear it most. It's a Long Story is produced by me, Andrea Gavin Becker, and is hosted by Dr. Ahmet Uluer and Lauren Harvey. Additional editing and production support is provided by the team at Resonate Recordings. Until next time,
Get a little older.
Live a little bolder.
It's a long story.
Resonate.